Hi, uh, good evening everyone. So, we'll be continuing our lectures on TNF alpha inhibitors which are FDA approved to be used in psoriasis. And today we are going to discuss Certolizumab Pegol. Now, Certolizumab Pegol is one biologic which not many of us are very familiar with, at least I'm not as much familiar with this biologic. And this is the fourth TNF alpha inhibitor which is FDA approved to be used in psoriasis. Okay, clear? So I thought that we should discuss this molecule as it has received FDA approval, and we at many centers it is still used. Maybe not in India, but other centers do use Certolizumab Pegol. So it's a good idea to know about what is this biological, how does it act, and how is it different from other TNF alpha inhibitors which are used in psoriasis, namely infliximab, etanercept, and adalimumab. And it's better idea to just complete the series as whole and finish with the TNF alpha inhibitors which are used in psoriasis. So it's a good idea to just go through this lecture, and so that from next week onwards or further we can start taking lectures on individual interleukins and the biologicals that inhibit them. Okay, so with that being said, we can start our discussion on Certolizumab Pegol in dermatology. Now, Certolizumab Pegol is a recombinant. Nearly all biologicals are recombinant. It's a humanized because it is Certolizumab, Zoo. Any biological which has the prefix or not a prefix, which has a segment by the name of Zoo, ZU is humanized. So there's Z here and there is Z here. Okay, so you'll remember that if any biological, for example, you have trastuzumab or bevacizumab, so these are all humanized. Okay, it's a humanized antibody fragment. Now, what we mean by antibody fragment, we'll discuss in the next slide. The FAB antibody fragment is conjugated with polyethylene glycol. Okay, so what essentially is, in the previous video on etanercept, we had discussed the basic structure of an immunoglobulin. This is the antibody binding site, which is FAB, while this is the constant region, which is FC. Clear? Now, what happens in Certolizumab Pegol is that, let me redraw it. The FAB fragment is conjugated with polyethylene glycol moieties or polyethylene glycol, you could say polyethylene glycol molecules. So it is conjugated with that. So polyethylene glycol is conjugated with the FAB fragment. Now what advantage do we have when we combine these two different molecules and form a new molecule of Certolizumab Pegol? Now the PEG portion or the polyethylene glycol portion, it extends the half-life of the FAB segment to around 14 days. Clear? So it increases the half-life of FAB to 2 weeks. We are clear on that? It also decreases the metabolism and elimination of the molecule. Now remember that these all are proteinaceous molecules and they will get cleared by the body after degradation to simple proteins and amino acids. So it decreases the amount required, decreases the time required for metabolism and excretion of the body, excretion of the immunoglobulin. Now, we all know that all immunoglobulins are removed by the kidney, so it decreases the renal clearance, decreases proteolysis, and also decreases immunogenicity. Remember that these all are artificially created protein molecules and it's exogenous protein molecules. That means this molecule is an outside protein molecule, and because of that, when the body recognizes these protein molecules, it will form autoantibodies or anti-drug antibodies against it. So, by the addition of polyethylene glycol, it decreases the formation of anti-drug antibodies, thereby decreasing immunogenicity, and thus the molecule remains in this system for a longer duration and has a better efficacy in treatment of psoriasis. We are clear on that? Now here is the same thing that we were discussing in the last slide. This is a normal immunoglobulin. It has a Fc, which is a constant or crystallizable portion of the immunoglobulin, and these are FAB or the antibody binding sites. What happens in certolizumab is that only the FAB portion is taken or created in a recombinant form, and then it is attached to polyethylene glycol molecule. Okay, and this becomes one big molecule of certolizumab. So we are clear that certolizumab is a combination of FAB portion and polyethylene glycol, and that is why a suffix is added to show that this is the additional molecule which has been attached to certolizumab, making it Certolizumab Pegol. Clear? Certolizumab neutralizes both membrane-bound and the soluble TNF-alpha. I have told you in previous slides that you have a membrane-bound TNF-alpha and a portion of it is cleaved and it remains in circulation. This is the soluble TNF-alpha. This is membrane-bound TNF-alpha. Both of them have the nearly same action. When the soluble form binds to the receptor of TNF-alpha, here it binds to the receptor TNF-alpha, the signals are nearly the same. So these two kind of TNF-alpha are inhibited by certolizumab. Now bioavailability is about 80%. Certolizumab is a subcutaneous injection. And remember that drugs which are given by any other method than intravenous, they have a decreased bioavailability. So subcutaneous injection of certolizumab has a bioavailability of 80%. T-half is 14 days. We all know that PEG increases the T-half of the molecule, and because of that it's nearly 2 weeks. Peak level is seen 54 to 171 hours. This has been mentioned in the product insert, which is roughly about 2.5 to 7 days. Okay. It is although the metabolism data is not easily available, but the PEG moiety is excreted in urine after cleavage. That means this is the FAB portion and this is the attached polyethylene glycol. It undergoes cleavage into two different parts, the FAB portion and the polyethylene glycol, and both of them are excreted by kidneys. This will undergo further proteolysis. Wait a minute. Further proteolysis, but both of them will be excreted by kidneys. Clear? Now, how does certolizumab act? It's a subcutaneous injection and binds to TNF-alpha and then prevents its attachment to its receptor. Okay, so this portion, the FAB portion, what it does is, this is a TNF-alpha. Let me see if I can use a different color. Yeah, this is a TNF-alpha, and normally it will attach to its receptor on the cell surface and carry out the function. What certolizumab does is, it attaches itself to TNF-alpha. Here it is the attachment. And then this whole molecule is prevented from getting attached to the natural receptor, and because of that all the physiological effects that TNF-alpha has is not seen. Okay, and further, because the attachment of TNF-alpha does not happen with its receptor, there is decreased inflammatory cytokines, there is decreased migration of inflammatory cells, matrix metalloproteinases, and CRP, ESR, all acute phase reactances are decreased. These are the same mechanism with which all the TNF-alpha inhibitors act. Okay, so your Adalimumab, Infliximab, Etanercept all have the same action. Now, certolizumab does not have the Fc component, and Fc component is responsible for fixing the complement protein. So there is no cell-mediated cytotoxicity. So what do we mean by that? Every cell has few receptors on its surface, and when that surface is active, when the receptors are activated by the complement system, it will release some signals which will tell the cell that what you are expressing, these molecules that you are expressing, means that the cell is infected or the cell is inflammatory or it is detrimental. It is very disadvantageous for a cell to exist for the body, and the cell should undergo apoptosis. Now this is complement proteins which are activated by other molecules like infliximab, adalimumab and other molecules. So they show a certain amount of cell-mediated cytotoxicity. Since there is no Fc component, it does not fix complement, and there is subsequently no cell mediated toxicity. Okay. Now remember that in pregnant females, in which you might consider giving certolizumab, the fetal Fc receptor, or the receptor in the baby which is for the Fc component, does not bind to certolizumab. So there is no transplacental migration. So what happens is, normally immunoglobulins which are secreted in the placenta, they will bind to the Fc receptor in the fetus and will stay there. That is how transplacental migration of immunoglobulin happens. Since certolizumab does not have a Fc component, it does not attach to fetal circulation and thus is not transmitted to fetus, making it a safer biological in psoriasis, in pregnancy. Furthermore, it does not bind TNF beta, which is also known as lymphotoxin alpha. That's an additional point. Okay, let's continue further. Now, it has been FDA approved to be used in two indications. One is psoriasis, other is psoriatic arthritis. There are two different dosing regimens in psoriasis and in psoriatic arthritis. Okay, so one regimen is to give 400 milligram every alternate week. So you give 400 milligram. Every blue box is 200. The reason that I have used 200 is because it is supplied in that dose. The injection is supplied as one injection is one injection is 200 milligram of certolizumab. So you give two injections together, wait for 2 weeks, give two injections, wait for 2 weeks, give two injections, wait for 2 weeks, give two injections. Clear? And you keep on doing it till psoriasis is resolved. So one regimen is 400 milligram every other week. Another regimen is to load first with 400 milligram at baseline, day 0, after 2 weeks and further after 2 weeks. And then shift to 200 milligram every other week. That's another dosing regimen. Okay. So you load it first with 400 milligram, after 2 weeks 400 milligram, after 2 weeks 400 milligram, and then every 2 weeks you give 200 milligram. Clear? Till psoriasis clear. Is that clear? Okay. Now, usually we see the response at week 16, which is roughly equal to around 4 months. At week 16, if the PASI, as per the different articles, PASI 90, which is 90% reduction from baseline PASI at 4 months, is roughly seen in 40 to 45% of patients. If we do not see any response to certolizumab, it's a good idea that first we can try to increase the dose. So let's say if we were giving 200 milligram every week, every other week initially, we might consider increasing it to 400 milligram every other week. If still there is no response in next 2 to 3 months, you might consider abandoning certolizumab and going to any other biologic. Am I clear on that? Now for psoriatic arthritis, it is the same regimen which I have told you in previous slide. You start with loading dose 400 milligram every 2 weeks, 3 doses, then every 2 weeks 200 milligram. Okay, and keep on giving it till the arthritis is under control. It's the same regimen. Now other uses of Certolizumab Pegol is the one use that I found was isolated case reports in neutrophilic dermatosis like Behçet's and pyoderma gangrenosum. I was not able to find this use in other dermatoses, but many, if you want to extrapolate the uses of certolizumab through other TNF-alpha inhibitors, so all the granulomatous disorders can be included. But as I said, the experience of using certolizumab is less as compared to other TNF-alpha inhibitors. So it is better that we stick to case reports which have been mentioned. So other use apart from psoriasis and psoriatic arthritis in dermatology, we can also count as Behçet's and pyoderma gangrenosum. Now apart from that, certolizumab is also approved for rheumatic arthritis and also for juvenile idiopathic arthritis Crohn's disease. So these are the other non-dermatological uses. But in skin, it is approved for psoriasis, psoriatic arthritis, Behçet's disease, and pyoderma gangrenosum. Now, how do you store certolizumab? It comes in a single syringe or an auto injector. So, in a single syringe, you have to push the plunger. In auto injector, it is spring loaded mechanism and the plunger pushes or the dose is administered automatically. Each syringe contains 200 milligram equivalent of Certolizumab Pegol. It also comes in a vial form, a lyophilized vial. So it's 200 milligram per ml and you dilute it with 1 ml of bacteriostatic sterile water. Similarly as you do it for etanercept. But nowadays the auto injector and single syringes are the most commonly formulations available. We can only use vial in, let's say, in academic settings or when you are giving pediatric doses and you have to change the dose from 200 milligram to something smaller. It is stored in refrigerator from 2 to 8 degrees Celsius. It must not be frozen, and even if it gets frozen, you cannot use it. So let's say you put certolizumab auto injector in 2 to 8 degrees Celsius and by mistake somebody puts it in a freezer and now it has frozen and you think that you can keep it out at room temperature, allow it to thaw down, become liquid again and you can use it. No, you cannot use it. If it is frozen once, it is better discarded. Okay, and any certolizumab which is not stored at 2 to 8 degrees Celsius have to be used in less than 24 hours of taking it out of fridge. Okay. Auto syringes, which is the most common available, they can be stored at room temperature for 7 days at the most. Okay, at the most, let's say if you want to use it, but the issue with that is that the efficacy is not that much and it does not have any preservatives. So the vial may get tainted, it may get contaminated, and it is not at all advisable to use a vial which has been staying at room temperature. Better is to stick to this guidelines, which is to be used in within 24 hours. If you are using vial and you have reconstituted it with 1 ml of bacteriostatic water, you cannot keep it at room temperature for more than 2 hours. Clear? So you cannot use it after expiration date. You have to protect from light, and no preservatives are there in certolizumab. So you need to use it as soon as possible. Baseline investigations are same as CBC, LFT, KFT, CRP, urine routine microscopy to rule out any infections, Monto test to rule out tuberculosis, IGRA to confirm that, chest radiograph to find out any latent foci of tuberculosis, viral markers including Hep B, Hep C, HIV, ELISA to look for any other immunosuppression and additional comorbidities, and to look at any signs of infection. So remember that TNF-alpha is actually very responsible to initiate inflammatory cascades, and we require inflammatory cascades to fight the infection. So if there is no TNF-alpha because of certolizumab, patient might not be able to fight infections adequately, and if there is a foci of infection underlying in the body, it may flare up leading to sepsis. So we are clear on that. These are the same baseline investigations which we had discussed for infliximab and etanercept. Now, as we have already mentioned that it is a subcutaneous injection, so you take the vials or the auto injector or syringes out of the fridge, allow it to reach to room temperature, which takes about 30 minutes. Okay, then inspect for particulate matter and discoloration. Now the vial or auto injector can have a little bit of particulate matter because it's a protein derivative, but little bit is okay, not visible clumps or dirty clumps. If there is presence of any of these in the vial, discard it, you cannot use it. Okay. After diluting, if you are using a vial and you have diluted it with bacteriostatic water, after diluting, you just gently swirl it for 1 minute. Remember that if you are going to violently shake any liquid that has protein in it, it will froth, and you cannot use a frothy biological. Okay. So just gently swirl it to mix it around. If it's an auto injector or syringe, you need not worry. It does not have any preservative, so you have to discard any unused portion and discard all unused certolizumab after 24 hours in fridge. Okay, so remember that if you have left any unused and use. Let's say you're giving doses in pediatric population and you have to give 100 milligram. The rest 100 can be used within 24 hours. But if it is not used within 24 hours, discard it. Clear? Now, Cimzia is the trade name or the name of the biological, the marketing name of the biological, the same as you have Remicade for infliximab or Enbrel for etanercept or Humira for Adalimumab. It is Cimzia for Certolizumab, and these are the injections. These are the syringes of Certolizumab. Each of them has 200 milligram. Okay. Now this slide shows the injection areas for subcutaneous injection. I've taken this image from the Adalimumab product insert so that I can show that these are the areas which can be used to give subcutaneous injections. And I'm going to reiterate or tell you again that let's say this is the umbilicus, you have to leave an 1-inch area around the umbilicus, and it's a good idea to divide it into quadrants. Give one injection here, one injection there next time, one injection here next time, and one injection there next time. And always, whenever you're giving a subcutaneous biological, always mention the site very clearly. It's a good idea to draw a diagram. Mention the site very clearly so that you know where you've injected previously and you don't repeat the sites. The sites have to be changed every time you inject biological. Clear? Other areas include the back of the arm, the thighs, apart from abdomen, the thighs for subcutaneous injection. Clear? Now this image is also taken from the Adalimumab lecture. You have to keep it at 45 degrees. Make sure the syringe is inside the subcutaneous fatty part after pinching it. You have to pinch it. So if this is the, let's say, abdomen, so you pinch it a bit and then inject into the subcutaneous part and inject it fully. Clear? There are many instances in which you cannot use any biological, especially Certolizumab, and these are nearly the same contraindications that we have seen in previous TNF-alpha inhibitors. So, absolute contraindications are that if you have any known hypersensitivity to Certolizumab Pegol, or let's say you have a hypersensitivity to polyethylene glycol, or you have hypersensitivity to any other components of Certolizumab. That means any let's say if you've added some diluents or some emulsifiers or something and you are allergic to it, you cannot use these molecules. The concurrent administration with anakinra or IL-1 receptor antagonist is not recommended. It increases the chances of severe infection. It may also increase the chances of malignancy in the long run, and it has been shown to prove no further additional benefit. So do not combine with anakinra. Any chronic or localized infections including tuberculosis, so you cannot give this medication, Certolizumab. Additionally, sepsis or severe infection. If a patient is in sepsis, you cannot give TNF-alpha inhibitors. Yeah. Now, relative contraindication is family history of demyelinating disorders, including multiple sclerosis or other disorders like Guillain-Barré syndrome. And it is also said that if a patient has a first degree relative of demyelinating disorders, better to avoid TNF-alpha inhibitors. Remember that this side effect is seen with all TNF-alpha inhibitors. So Adalimumab, infliximab, etanercept, all of these contraindications. So you are not supposed to use them in patients who have a history of demyelinating disorders in family. Infections are one of the most common side effects seen with Certolizumab, majorly the upper respiratory tract infection, which is seen in 4 to 9% to as high as 18%. Now, this is one side effect which is much more common in Certolizumab as compared to other TNF-alpha inhibitors. Specific infections like nasopharyngitis has been seen in 7 to 20% of patients. Urinary tract infections seen in about 8% of 8% of patients. Opportunistic infections are very rare in Certolizumab. Okay, so remember that previous TNF-alpha inhibitors like etanercept, Adalimumab, infliximab do show a lot of reactivation of prior infections or newer opportunistic infections, but it is found to be extremely rare in Certolizumab. Now, what do we mean by that? We actually mean that 0.1% chance, less than 0.1% chance is there. And opportunistic infections include all the deep fungal infections like aspergillosis, blastomycosis, candidiasis, and others, and also tuberculosis in our setting. So, tuberculosis is very important. Remember that TNF alpha is required to form granulomas, which is required to inhibit tuberculosis. So, if you stop TNF alpha, granulomas will not be formed and TB will run rampant. It will increase and you will have a case of disseminated TB in your patient. Do not combine with anakinra or abatacept or any other TNF alpha inhibitor for that matter. There is no additional benefit in combining two different TNF alpha inhibitors. It will increase the chances of severe infections and malignancies. So it's better to avoid certolizumab in patients who have active infection even if it is localized. In geriatric population, age is more than 65 years. Patient with other comorbid conditions like diabetes mellitus, uncontrolled sugars, or severe hypertension, HIV. So these have to be kept in mind. Patient taking concomitant immunosuppression like corticosteroids or methotrexate, it's a better idea to avoid TNF alpha inhibitors in those patients. Like all TNF alpha inhibitors, the risk of TB is very concerning and very important in certolizumab. So the limit for Monto test is decreased to 5 millimeters, and any concomitant immunosuppression increases the risk of developing tuberculosis. Okay. Consider TB if the patient develops any newer signs of infection to show that TB could be one of the causes. So consider tuberculosis also in your differential. If a patient has any foci of latent tuberculosis, treat it first. Okay. If they have family history or contact with tuberculosis, give a good prophylaxis and then start certolizumab. Remember that in our country, TB is endemic. Many of us are infected with it, may not develop disease throughout our life. And there is one book that I'm currently reading which says that 10 patients are infected with tuberculosis, but one is going to develop the disease. Okay, so remember that other 9 are infected but do not develop the disease. So you have to search for it so that if you find any focus of tuberculosis, you treat TB first and then go ahead with TNF alpha inhibitors. This is the same flowchart which we had discussed 3 times before with Adalimumab, Infliximab and Etanercept. So this time I am not going to discuss it. This will stay on your screen for at least 5 seconds and then I will move forward. If you have any kind of doubt in understanding this flowchart, I would suggest you go back and see the video on Adalimumab where I have discussed this flowchart in detail, and so that you may have some idea of how to go about using certolizumab in patients who show any signs of tuberculosis. Malignancy is seen in patients where therapy is initiated in pediatric age group, especially in non-dermatological uses like juvenile idiopathic arthritis or maybe pediatric Crohn's disease. So if the first dose is received before 18 years of age, the chances of malignancies increase. Most of the common malignancies are lymphomas, including Hodgkin and non-Hodgkin lymphoma, and they account for roughly about half of all malignancies that develop. Additional immunosuppression given during the treatment or therapeutic phase is an independent risk factor for development of malignancies. Okay, and median development of malignancy is 30 months of therapy, range of 1 to 84 months. Now remember that this data is for all TNF alpha inhibitors. So all TNF alpha inhibitors have a single data about it. There is no separate data for certolizumab, and this is the number that they mention in the product insert. So we'll go with that only. Other malignancies include acute and chronic leukemia, melanoma and non-melanoma skin cancer, Merkel cell carcinoma, and hepatosplenic T-cell lymphomas, especially if the patient is concurrently taking azathioprine or 6-mercaptopurine. So keep in mind, before combining two different immunosuppressives with or any other immunosuppressives with TNF alpha inhibitors. Now, anti-drug antibody. I've said that the chances of developing anti-drug antibodies is somewhat low in certolizumab because the FAB portion, which is conjugated to PEG portion, the PEG portion kind of prevents immunogenicity. So the formation of autoantibodies is less. So if 400 milligram every 2 weekly is given, the chances the autoantibodies are seen in 7% of patients. If 200 milligram bi-weekly is given, then 19% of patients, and roughly one third to one fifth are neutralizing antibodies. Neutralizing antibodies means that the antibodies attach itself to certolizumab and then degraded, and because of that, it neutralizes certolizumab. So one third to half of those antibodies are neutralizing. Other side effects like psychiatric disorders have been reported with certolizumab, mainly anxiety, bipolar, and suicidal ideation. So we need to keep an eye out for them. Ophthalmic side effects include optic neuritis, retinal hemorrhage, and uveitis. Congestive heart failure is a relative contraindication for all TNF-alpha inhibitors, but it has been found to be very rare in certolizumab, and I suspect it's because certolizumab is not used that much, that is why it's rarer. But we need to understand that NYHA, New York Heart Association, grade 3 and grade 4 are near to near absolute contraindication for any TNF-alpha inhibitor. And if your patient has even slight chances of heart failure, it's better to keep them monitored, and if possible, look for any other drug rather than using certolizumab. Now, demyelinating disease, I've already discussed that all TNF-alpha inhibitors are not supposed to be used if a patient has demyelinating disease. Less than 0.1% of patients may develop demyelinating disorders on certolizumab. Okay, so make sure that you take proper history to rule out, even if it is present in family history and primary directly related blood relatives. It's better to avoid this drug in those patients. Now, few other side effects are alopecia totalis, which is very rare, paradoxical psoriasis. Now, remember that paradoxical psoriasis is seen in all TNF alpha inhibitors. So, the treatment for psoriasis can sometimes lead to a flare up of psoriasis because psoriasis is a very complicated disorder. It has a very complicated immunopathogenesis, and so suppressing one arm of immunopathogenesis inadvertently increases the chances of the other arm. So if you want to revise or learn more about how does psoriasis happen or what is the pathomechanism of psoriasis, there is a separate video on that. Go to that video and just look at that video and revise why does psoriasis happen, and you'll be able to understand these TNF-alpha inhibitors and other interleukin inhibitors much much more easily. Other side effects include dermatitis, erythema nodosum, and urticaria. Nephrotic syndrome and renal failure have been rarely reported. However, the product insert mentions that in case of renal derangement, if it is mild, you need not choose, you need not change any dose. But if it is severe, it's better to consider some other drug. Now, few occasional case reports do mention menstrual disorders as side effects, but there is no significant effect on fertility. So that's another thing to look out for. Now, pediatric patients should be brought up to date with all their immunizations. Patients with certolizumab may receive concurrent vaccination, but they cannot be live vaccines or live attenuated vaccines. So remember that you cannot give live vaccines and you cannot give live attenuated vaccines. Attenuated vaccines. Clear? So no live vaccines, and this is the same for all TNF alpha inhibitors. No live vaccines, only kill vaccines or subunit vaccines or mRNA vaccines. Clear? Drug interactions, no recombination with TNF alpha inhibitors or anakinra or abatacept. There is no added benefit, and it increases the chances of severe infections tremendously. Other interaction is that 6-mercaptopurine or azathioprine should not be given with certolizumab, otherwise chances of hepatosplenic T cell lymphoma increases. Hepatosplenic T cell lymphoma, pardon my bad handwriting. Hepatosplenic T cell lymphoma chances are increased when the patient is receiving azathioprine, 6-mercaptopurine with certolizumab. Okay. Additional side effect which has been mentioned is that CZP or Certolizumab Pegol can falsely increase APTT by its hindrance of complement system. By its hindrance in the coagulation system. So it may falsely increase the APTT value. So keep an eye on that. No case reports mention bleeding as a sign of any side effects of CZP. So it's better just to keep an eye out and just evaluate the patient for increased APTT values. Now, the pregnancy, the data is of course lacking in all TNF-alpha inhibitors and to be used only if necessary. Now, it's in older category, it is category C drug. Older pregnancy category is category C, and that's something unique about certolizumab because all other TNF-alpha inhibitors are category B. And I think it is just because the data is not much available, studies have not been done, and because of that, a category C was given to certolizumab. So there is no such, the newer pregnancy category is not mentioned with certolizumab, but I would suggest that it would be somewhat safer because the lack of FC portion allows it to not be migrated enough to the baby. So the transfer through placenta is minimal to none, and in baby's serum it has been found to be non-existent. So when they checked the baby's serum, babies of women who had to receive certolizumab during pregnancy, they did not find much values, okay, much concentration of certolizumab in baby's serum. Similarly, in lactation, there's minimal to none transfer of certolizumab to the baby. So it is somewhat a very safe drug to be given in pregnancy, but all the pros and cons have to be weighed. If the improvement, or let's say if the advantage of using certolizumab is much more heavier as compared to the disadvantage, you talk to your patient, explain them all the associated side effects, and then consider certolizumab. Am I clear on that? This should be done with all different drugs. You need to discuss with your patient that these are the side effects, these are the effects, and since the effect is much more than side effects, we should consider taking this drug. We are clear on that? And with that, I'll finish this lecture on Certolizumab Pegol. It's, I think, the shortest lecture of TNF-alpha inhibitors because it's not much in use. The other TNF-alpha inhibitors, namely Adalimumab, Infliximab, Etanercept, are more widely used. So much more data is there. So much more information is there. So apart from this lecture, you won't be requiring any other source to learn about Certolizumab. The reason that I discuss Certolizumab is because it is one of the FDA-approved treatment for psoriasis. So we should discuss and cover it so that the whole series is completed as a whole. But most of your questions will come from these three TNF-alpha inhibitors, Etanercept, Adalimumab, and Infliximab. And along with Certolizumab, these four TNF-alpha inhibitors are FDA approved for psoriasis, and thus with Certolizumab, we finished the series on TNF-alpha inhibitors in psoriasis. In subsequent weeks, in coming weeks, we'll be discussing of other biologicals which are used in psoriasis. For example, let's say Golimumab or Ustekinumab or Secukinumab. So we'll take one biological every week. Till then, if you have any doubts or suggestions or queries, you can email me anytime, or you can mention it in the comment section, and I try to reply them as fast as possible, and I do reply to all comments. So just write your doubts, suggestions, or any other newer question that you might have been asked and don't know the answer to. We can search together and find the answers. With that, I'll finish this lecture on Certolizumab. Thank you for listening to it, and we'll return again next week to discuss another biological. Okay, adios. Remember to drink lots of water in the summer, and make sure you practice sun avoidance with a good umbrella and a good sunscreen. And you tell your patients to do the same. With that, bye-bye, and we'll meet you next week.